referred. That means, are they completing referrals? You can refer somebody, they get to the facility, then once they get to the facility, they don't access the services as they're supposed to get. So that was the main objective of the pilot. The toolkit components. The toolkit had an initial assessment of referral system and its monitoring. Basically, qualitative data was taken from our pilot facilities to find out what kind of structures do they have to support referrals. Then we also had in the toolkit some generic indicators. Some of the generic indicators that we had were referral initiation. How is referral being initiated? Is referral being completed? The other component of the toolkit, we had some generic tools for collecting, analyzing, and reporting the referral system monitoring data. And the last component of the toolkit was we put in a decision guide for managers. These are district health management and district health managers to guide them on how to use some of the referral data that they are collecting. So how did we go about the pilot? We selected some sites. The pilot was conducted in 2 districts, in Central, Nyandarua North and Nyandarua South. We selected 10 facilities in Nyandarua North and Nyandarua South and their link community units so that we can see how referrals are happening from the community to the facility and from the facility to the community. Stakeholder identification, of course, in Kenya we know that before you implement a pilot, you go through the GOK processes. So we identified key stakeholders. The district medical officer of health was involved in this pilot. The district health management team, basically, the health records information officers were all involved in this pilot. Then we trained on the toolkit, and we also held an initial assessment of the referral system in the facilities. These were mostly level 3 facilities, those are health centers. And we assessed their capacity to do referrals, their capacity to refer, do they have the correct data collection tools. We adjusted some of the data collection tools to include data elements so that you can adequately capture numbers who have been referred in and numbers who have been referred out. Then we went back to the facilities for an evaluation and talked to them about how the pilot was. Were they able to collect referrals data? What were some of the challenges and how to improve on them? Then, of course, we are currently finalizing the pilot report. Some of the key findings, and this is merged with conclusions, is feasibility. Feasibility is the toolkit is applicable in Kenya. You can actually measure referrals with this toolkit in Kenya, and some of my colleagues also performed the same activity in Thailand, so it's applicable in diverse contexts. Then there is low burden of data collection to providers, as majority of data elements are routinely collected. This is in Kenya. In Kenya, the good thing about Kenya is that some of our registers have the data elements for referrals monitoring. So there was low burden of data collection. Our pilot sites told us that we need to streamline user-friendliness. The toolkit, they said, was too bulky, and we took in those comments positively, and we're going to adjust the toolkit. Then utility of the toolkit, it's useful for assessing the strengths and weaknesses of the referral system in Kenya. In Kenya, some of the weaknesses that we have are, do we know if people are completing referrals? And why are people self-referring themselves? So it's useful for assessing that. Then the study was limited by resources, but we were available to address some recommendations and findings. The good thing about the study is that it facilitated the profile, raising the profile of referrals and the role in health system strengthening. People started talking about referrals in the facility, which was a good thing. They started talking about them in their district health management team meetings, etc. Validity, good internal validity of data. We collected both qualitative and quantitative data based on the pilot sites that we had. And there were high agreement rates between the data and the appraised status of the referral system. Then data quality issues were identified and we addressed them. Transferring of referrals data from the registers to the toolkit, there were data quality issues, but we were on site to address them. So some of the recommendations, some of the good things that came out of this pilot was, there is a referral strategy. The national referral strategy adopted some of our key indicators from the pilot, which is a good thing. And the referral strategy will be used to train healthcare workers on the referral system in order to strengthen the referral system and also to adjust the tools. Thank you. Thank you, please.